one a human being, and the other is a person who asks questions. Now, if the person who asks the question, they'll be asking many questions both to the computer as well as the human. And if the person who is asking the questions can't make out the difference between who is answering the question, whether it's a human or a computer, that's when, the AI has reached a benchmark of having human behavior, where you can't make out the difference, whether it's a human answering or whether it's a machine answering. And that's where you have crossed the Turing test. And that is what has happened with OpenAI, Bard, and all these open source, meta open source LLMs coming out. So once you have passed the Turing test, that's when they believe that, AI is not something like a calculator. It's how it can behave like human beings. So that's the benchmark where they kept as a Turing test. So if you pass the Turing test, that's when you say that AI has become like human beings, or can behave like human beings. Go to the next slide. So this is a basic history of AI. AI as a term was first coined in 1956. So this was a conference in Delano where all the scientists, not only mathematicians, but also from psychologists, many of these scientists from different fields came together, and they said we need to build an artificial intelligence which basically can behave like human beings. This was the starting point. And this is where the word artificial intelligence was coined. So it was not there to solve a mathematical problem, but can we create something which can be intuitive like human beings? Then you have different, 1958, you had a perceptron. This was a program which was developed. And it was a program that was developed from a neural network, like a brain-inspired program. So they were thinking, can we develop a program which behaves like a child? So you don't have to go that far intellectually, but as a child, can you create a program? And this was the first brain-inspired program. Then in 1960s, was a big boom. So there's always a climb of booms and busts. So the AI boom started in 1960s, where the government of US also invested a lot of money. And then you had the first Turing test, where they actually tried to create a chatbot for mental health. And they tried to see whether it could emulate human communication, but it never passed it. So this was the first test which they had. And then 60s and 70s was a great boom. You had a lot of people making applications for AI using neural network. Then it was a bust. So 1980s was a pure bust. They came into conclusion that nobody can make an AI which has intuitive or can recognize speech, communicate as human beings. So 80s was a downtime. A lot of people were withdrawing money from the funds and things like that. But there is always enthusiasm. So in 1960s, you have an emergence of natural language processing. So in the 90s, you had computer vision, which was using neural network to actually create AI. So you have a lot of transformers. The main thing of AI actually working are something called transformers, where you can identify entity. You have linguistic people, because language is very tricky. To understand language, there is always context to it. And you have words, similar words having different meanings. So these transformers were built basically to understand context, giving in the right context. And then after this, in the 60s and 2000, was the big rise of big data. Now, big data, you have 4 attributes, which is volume, like the amount of data which comes in. So you have like internet, then you have velocity, which is high speed internets which have come in. And then you have variety, which is like an application. You have social media networks, you have Netflix coming in. It's like, if you look at it in a way, it's like an electric current. Electric current is a source of energy which runs your fan, ACs, refrigerators, washing machine. Similarly, once you have transfers of data, communication like an internet, and if it's of great bandwidth, you can start building application. So the volume and the variety, they started increasing. And then you have application to chunk this big data. The chunking is very important for machine learning, so that I know what you like, what you dislike, what I need to recommend. So all your e-commerce and these kind of sites starts taking off. So you had programs called Spark NLPs, you had Hadoop, which used to chunk this big data for machine learning and try to help e-commerce sites to any kind of commercial applications. So this was very interesting. So once we have a natural language processing, then we had some technology called semantic search. So IBM Watson was the first one who made semantic search into showcasing that. So there is this program called Jeopardy. Jeopardy is a quiz show where there were 3 human beings and there was a computer, and they were asking questions, and IBM Watson won. So Watson had the capability of running these search programs and understanding what is human language, because they had a natural processing program running at the back end, and it could tell you what is the right answer much faster and more insightful than a human being. So this was the first thing which wowed everyone. The second one is AlphaGo by Google. So there is this game called Go. It's mostly played in Korea, China. So if you look at chess has approximately around 3 billion moves as a game. And chess games were already developed much before, but you have the combination of a finite combination of that. Go game has 10 to the power of 306 moves. It's very difficult, it's very intuitive. And there is this movie online, if you go AlphaGo, it's on YouTube, it's free of cost to watch. You can actually see the machine beating human beings. So in this you have to be very creative in understanding what you need to play. So we thought, there is a scientist called Richard Feynman, if you know of him. He was into the guy who made atom bomb, he was one of them. So he had said that, playing chess is a very heuristic game. So it's a program. If this move doesn't work, you'll know that that move will work. It's very heuristic, if not all those kind of combination. But if somebody plays AlphaGo and defeats human beings, that's when you know the machine is actually having an insight and creative thinking, which he knows exactly how to play, because the combination is very wide and large. And this is where Google Brain came into play. So this was the Google Brain team who was creating these kind of programs, and a company called DeepMind. DeepMind was into deep learning. So they used to create these kind of application and give gamers to play it. The gamers, how they play it, the program used to understand, and then have a kind of reinforctive learning. So what happens with all these kind of models is that they have recursive and reinforcement learning. So if you start using it, they start learning your behavior patterns and they can behave like you. And they make better. So when you have so many machines connected, you can actually have so many synapses or neural networks. The machine starts outperforming you in a short period of time. So this is what actually happened. So then once machine learns what you can do, or humans can do, they will start generating. So it's like a small child. He starts listening to what you have, how things are. Then he starts emulating. So he starts talking. And that's how the machine is, The machine, once it knows what you do, how you do things, it can start creating music, text, videos. So I won't get the technicalities of it, how it actually happens. So there's a lot of maths behind it. But this is what it does. So once you have reached that capability of understanding, having the deep mind, you can be very intuitive. and start behaving creatively. And then you start coming up with, I think YouTube has, you can create your own music, image, videos, all these kind of things. And then you have the arrival of base models. So most of the applications are built over these base models, because you have open source model which is like Meta, which you can actually download onto your own server and start running it. But the other ones are basically API driven. So API is basically a protocol which you ping it and start getting answers. So BART runs on that. BART runs on something called Palm2 model. Then you know about OpenAI, ChatGPT, Meta of Facebook is called Llama, Falcon. These are two open source models. And Anthrophilic, that's the A1. So you have all these kind of base models. Now the beauty about this base model is once you have this base model, you can build anything above it, on top of it. Let's go to the next slide. So in healthcare, what can you do with this in healthcare? So medical education and services, I will show you some kind of demos what we have, but it can be used in diagnostic. So the minute you have data, the main thing was when you have infrastructure and volume of this data, you can actually start building applications of deep learning into the system. Earlier it never happened because you never had these kind of infrastructure in place. Now because you have these kind of infrastructures, you can actually build stuff. So in diagnostic, you can do about radiology, clinical decision making, mixed reality. I think the Vision is coming out by Apple. That's a mixed reality. So you can do a lot of these kind of medical engagement program, research, drug discovery. Google has also made an open source a software which is called AlphaFold, which actually you know how your protein types are twisted, and you can use those kind of information to create more new drugs. Then you have other service like hospital claims. You have the machine learning or fine-tuned models which can go through these kind of for prior insurance claims and things like that. It's better when I show you a demo. Can we move? So where DocMode came into play. So we were dwelling into AI, how we can create a use case of AI. So DocMode is like a CME webinar come courses for healthcare professionals. So we realized that whenever we used to do a webinar or a course, and when the doctors used to give the lecture, students or whoever the learners had questions, and there were no response on time. Or when the faculty is left, the response time, even if they used to give a response, the conversion time was like 48 hours or whatever, or sometimes they wouldn't be. So then we dwelled into this whole system that why don't we create an AI? The answers on the fingertips. You can ask whatever you want, and we can give you those answers. So then what did we need to do about that? So for clinical service or knowledge base, we had to find data sets. And this is some of the data sets what we have from PubMed, books, and we had to create a model. So you have your base models existing, you need to fine tune those models giving this data set so that they are aware of these kind of medical knowledge. So these are the few data sets we put in, and then we create a product called AIDE. Now AIDE is basically to assist. So basically having medical Q&A, medical summarization, and it is used as an educative tool, not to treat people, but as an education tool to reinforce his learning. So this is one of the Q&A. You can ask a question on AIDE, you can log into DocMode. You can ask a question, I hope it's clear.
What is the classification and mechanism of action of, I don't understand, molecule K?
So the beauty about this, other than OpenAI or BARD, is that this goes through a 16 million reference set of articles, and it gives you references, which BARD and OpenAI generally hallucinate when it gives you an answer. What is hallucination is, It's supposed to answer, it gives you a right answer, but you don't know whether the reference articles exist or not. But this, you'll never have an hallucination, because the tech is used not only using large language models, but also it's a hybrid search, which you can actually pull out the references. So, and plus you can regenerate. So you have answers coming in, and you have reference source from all the PubMed sources which are there. You can click on it and it'll open. You guys can actually go and start using it. So there's another example. So this is basically a drug-drug interaction, heparin and warfarin. And it goes through these articles and start giving you. So the difference also it is that it gives you a one-shot answer. That what is the whole thing, you don't need to search about it, it gives you from where it's taken. So this is totally a process where it actually summarizes these articles and throws it up. This is another product which we made, is basically chat. You can ask questions, this is for doctors, where you can, so what I did was, I took a case study of a doctor and I pushed it up onto the AIDE chat to see whether it gives me the right diagnosis what the doctor gave. It was right. So it can also think, with all the kind of the test, what values you put in, it actually thinks intuitively, gives you an answer. And this can actually help a lot of primary care places where the doctors have to double check. But when you're confused and like the GP doesn't know everything what is around, you can ask certain questions and try and see whether they're giving the right answers, and then do some test and see that it's right or wrong. So it saves up a lot of time, and it gives you the whole answer. The diagnosis is basically, we checked with the doctors what was the treatment, and the diagnosis, it gave the same kind of thing. And this is basically an LLM which is fine-tuned for medicine. It's not your OpenAI or Bard. It's very fine-tuned for medicine. That means it understands the language of medicine. So also how it helps patient. So for example, when my dad went through MRI, all these kind of scans, I'm not from a medical background, I couldn't understand what it actually says. I just copied what it says, put it into the chat, asked it to summarize in a layman's language, tell me what's the problem. And it actually summarized in a language that I could understand. So for doctors also, when they want to give patients out some kind of information, you can't give this information because they won't understand. So then it summarizes and gives you the right kind of answers. And he can double check what he's trying to say, and it gives those kind of information out. Now go back. So how it can be used in the pharma industry is creating a dialogue agent for medical representatives. Now when you have kind of training programs for certain drugs, and you always have this training, and you have a lot of people leaving and going in the same companies, moving out to companies. So this can facilitate training. And even when a doctor asks you a certain question about a molecule or a drug, the AI can throw up accurate answers with references what the doctor wants. So it just gives you a tool where you have any kind of questions, you can just search on it and you're getting it with references. So that's something what AIDE can do. The second product, one of the products which Accenture actually developed was in US, is everything runs on insurance over there. So the minute you enter the doctor's clinic with what problems you have, the form is being filled out, sent to the claim provider, and you go to the doctor, and the entire process is done by the large language model and the AI to actually approve his claim. So you don't have that time, so minute he's come out, the claim is already approved. So knowing whether it's going to be a co-pay or he's going to pay on his own, whether these disease types are covered or not. All this is basically done by AI, so that the patient doesn't have the problem to book the appointment, see that his insurance claim is actually getting approved or not. Then we have something for clinical trials. So a lot of data set is required for clinical trials. First thing you can also do using is whether any trials are done before. You can actually do kind of a search. See those kind of reference material, whether there was some kind of trials or similar trials done. You can also use this thing, once you collect the data, you can actually say to formulate this in a way the approval party will accept it or not. So there is a kind of systemic format. Taking that data, it can create that kind of documentation faster than what humans can do and send it off for approval process. The other one is done in US. In India it will be a little bit difficult because we are very multilingual, is where you have patient interviews. So the whole patient interview is recorded, the doctor and the patient. So once the interview is recorded, it basically takes up the whole interview and makes a clinical note of it. And the treatment plan, everything has for this. And then it loads up to the electronic medical record systems. So the doctor has more face time with the patient rather than looking into the system. So whether it's synchronized or asynchronized patient interview, you can actually, the doctors, many of them are using voice. So you don't even have to dictate, you just have to have the conversation, the phone is recording your voice, you get the entire thing transcripted, and then you can create clinical notes. So next very interesting thing that we are experimenting is right now, other than LLMs, you might be heard about the multi-models which are coming. What are multi-models? It understands video, it understands images, it understands text, and you can ask a number of questions. It understands voice. So this is a multi-model. In what we'll be showcasing you is that you can actually take a photograph of your skin, ask what it is, it will give you an answer. Mammograph classification, genomics, radiology reports, all these kind of things. We'll go to the next slide. So this is how it works. Basically, you take an image, which is an X-ray, it converts into your vector formats, and then it goes into an adapter. You ask a question, and the output will say whether yes or no or whatever questions you have. This is how it works. I'll show you a demo, you'll have a better understanding. Okay, so we have two images here. Okay, and one is psoriasis, one is brain tumor. Now we have a model which we are playing with. The prompt is there. We'll write the prompt, we'll upload the image, and you check the response. So diagnose the image below and share the possible line of treatment. So this is the psoriasis image. It recognizes. It recognizes what it is, it tells you the line of treatment. Yeah, you can take the next one. You can reduce the, sorry, go back. Diagnose the image shared with you and also mention the possible causes of the same. Share the treatment as well. So this is a brain tumor thing. The beauty about this is that it recognizes whether it's a skin disease, it's an X-ray. I don't need to tell it. It can intuitively understand what it is and then gives a response accordingly. So, I mean, it's for you all to actually judge where we are going. You know, these tools will soon come out. Government hospitals where you have lack of doctors and facility. WHO has come up with a large language model guideline, I think 2 days back, which we'll always have to use this as a tool, because who will take up the liability is a big question. But this is how progress is happening, and I think future is very exciting. So whether it's in healthcare or across any kind of domain. If you all have any kind of questions which can be addressed to us, we'll be happy to answer. Thank you.
Yeah, please, I think there's a question there. Thanks so much. So our focus was for this presentation to have a use case. I believe the deliberation has been happening since morning, and we wanted to showcase what exactly are the use cases, and like Paulson ended, the judgment is out there. The line, like Hatangadi said, Sir said very clearly, we are in the era of AI. So it's not whether by choice you are entering it, or you can leave or close or not enter the door, you are already entered it. And now you have to respond in a way how you can use it. And whether you want to use it, there's somebody else who's going to already use it. And there are leaps and beyond what we can do is happening right in front of our eyes. Yeah, so please, your first question.
Yeah, actually it is interesting, but in dermatological classification,
Yes.
What is the percentage accuracy?
So right now when we look at the database and the data set, what you are pushing in, we are just training the model. So you can get, see, we need in medical health at least around 90 to 95% accuracy or much more, but you are getting an accuracy rate of around 80%. In image format files, it's very important that you have the right lighting. Even in an X-ray, you need those contrast levels which are coming up.
DICOM files.
Yeah, DICOM files. So these are some challenges which you have, and we have to see how better the machine can actually learn and start predicting.
There is some sensitivity with the programming in a way that it knows whether it's right or wrong. When it's right, it tells it's right. Whether it's any area of doubt, it mentions that this is an area of doubt. So you have to take it in terms of, especially for healthcare professionals on the other side, we are far more at ease. If there is not an healthcare professional on the other side, that is why we have to say trust your acumen.
Yeah, and it's caution then.
Yes. So this is very important. The image was my own. So I'm a psoriasis patient. So I was very happy with the response, plaque psoriasis. The other part, it identified the type of psoriasis also. So there are many types, and it identified the line of treatment also is very good. Of course, regionally, in terms of treatment, can it give the exact treatment? That is important. And this is where I feel a lot of intervention can come from the industry itself, because there is so much innovation happening right before our eyes. Especially, I'm just talking about in psoriasis itself and in other areas. I would like personally to give one use case of mine. When I looked at the data, when we put up this particular question up, there is one product which is just new 2017 launch. It's called Apremilast. It's a biomodulator, and there is one methoxtrate that is being used without change by many dermatologists for the past 10 years, but without even doubt, looking at the efficacy in terms of, there's a 50-50%, almost 55 kind of treatment, but it's put in, it's a chemotherapy oncology product, but in very minute modules it's given. So there is no study actually where you have an immunomodulator with with a chemo product. So this is a big gap. When we look at when we look at AIDE, we see there's no studies done at all. So this gives actually impedance to a lot of the industry, a lot of healthcare professionals to find gaps. And look at India, the thought leaders, the Western thought leaders, the data, the ideas, the research is all coming from there. We pulled out all the PubMed indexed articles. No doubt we have amazing thought leaders here. But to pull out gaps, this is where I think Indians will do a far more better job to do these kind of research where there is, you don't need big pharma to back you up for these kind of research.
Yeah, yeah.
So the initiative that we have taken is really good. In a way, you are helping doctors to get more information in lesser time. My question here is that I think, is it launched to the doctors of India, or is it yet to be launched?
So from a Q&A and answering point, the question Q&A and the chat version, that will soon be launched. But image recognition and those X-rays, that is still under development.
Okay, so one more question from my side was that what you are targeting the AIDE bot for which group of doctors basically? So yeah, maybe so that is my
So it's actually for all doctors, because if you look at something called Walter Kluwer's Up to Date also, you have one single app which is across domain, because it's knowledge finding. If you are a GP, you may want that knowledge, or if you're a super specialist, you want that knowledge. It can assimilate that because you have all the data sets which are there, which are all the journals and articles from PubMed, actually synthesizing and giving that information. So there's no difference between specialty currently.
For us, this is a small step. So this is one of the kind of initial first movers step, and then we look at building on this. We already are looking, like he mentioned, multimodal is going to be a big part of it. And then we are looking at, in terms of which specializations we'll look at it more. Because in the field of ophthalmology, already Google has done a lot already. So there where we can work out, where we can do much. Radiology, there are already, in terms of AI tools, already being adopted. It's not to reduce manpower, but it is to improve the efficacy of the outcome. So this is important. I think there's a lot of advantages where right now, as a clinical decision support system, AI can play a big role, what we have built, but we feel it can go much further. And I think the use cases, like I just mentioned, gaps for research can be identified.
You can use the same model for it.
Yeah.
Also, I feel that with respect to digital adoption, also there might be cohorts of doctors who.
There's no question about it.
Yeah.
There's digital adoption. Many would say we were just give you a background. 2009 we initiated DocMode Health Technologies, and we were going out in the market with 2G, 2G plus, and streaming programs. So there was not much landline, not much cable, but doctors had smartphones. They were already on the iPhone 4 and iPhone 3. So there's no doubt that digital adoption in healthcare is already there. In terms of use cases, we are a bit lagging, but I think COVID has really pushed us back in the game. So I think no one is here denying that.
Okay, thank you.
Is this, it's a very good work that you all have brought out with DocMode. I just had got a query that whether this is for diagnosis, which is a doctor's job, or it is for prognosis, that it guides how the disease is going to progress, especially when it comes to terminal conditions like oncology, etc.
That's a good question.
Yeah, so there's no boundaries yet. So it's, if you feel you are in doubt, you can ask AI, but it's up to you where you can. So for example, if you put the symptoms in, and you think that you can have differential diagnosis, then it happens.
I don't have a doubt. It was a query that whether it is for diagnosis or whether it is to decide on the prognosis. Basically, because all this actually says that if it is like brain tumor or something of that sort.
Correct.
Yeah.
What is the life expectancy of the patient after the treatment of
See, if all these, you need to chunk data. So right now, I just showed you a multi-model that it understands what it is as an image format, and it tells you what it is depending on the prompt. Okay, so it's very image driven and patient diagnostic. We don't have patient data yet. But the minute you start chunking in data, so even if you have a genome related data, age, you can actually have a machine learning and have these algorithms then. So in Taiwan, for example, if you're a smoker, you have cardiovascular disease, it can estimate, and you have cancer of grade 1, grade 2, whatever, it estimates your lifespan. So you have these kind of algorithms already there in, whether it's the NHS or
So it's putting risk scores, predictive equations, all of this together into the database. At the end of the day, it will also challenge them. It will challenge the source knowledge. This is what we are calling as secondary knowledge. The primary knowledge is the data that we have to get from the first source, that is the patient itself. So the primary knowledge can always challenge, and it should challenge. And we feel that going forward, the question was, in doubt was not personally for you. The question was if the person using it is in doubt. So the idea is that there will be always doubt, no matter at what level you will be in the medical fraternity or field, because environmental challenges are there. Healthcare is moving and at every pace differently. So I feel that at that level you need some kind of assistance, and today it will be that assistance tool. Just to elaborate a bit, we also have a nutritional tool in hospitals where it guides the patient and assesses the patient, screens the patient, and then we tell the acumen of either the dietitian or the physician in terms of what disease areas, and this is all by logic. There's no AI involved right now in it. In terms of what is the best nutritional treatment based on the guidelines. So this is logic. I'm just giving you that no artificial intelligence is used in this. Now imagine we already have this and it's used in top 20 hospitals currently. Imagine I infuse AI in this. So the AI is just going to work on the database. What is going to come out is going to be something very amazing. So it will do pre-planned diet charts. It will do in terms of disease mapping, because we are getting that kind of data. So we have been sitting here and seeing right in front of our eyes amazing stuff that is happening, just utilizing real world data, that is the primary data set, into these kind of base models and multi-models. Amazing things are coming out.
Hello. Hi, both of you. It's an excellent to watch this application of AI in this space. I just wanted to know, CDSS, it's like clinical decision support system, and yeah, as you rightly said, up-to-date replica, or I would say, it's far better.
I would say far better. We are just using AI, where their water coolers up-to-date has 7,000 HCPs summarizing the data. So it's human intelligence versus, but by far, I don't think we want to put ourselves in the same line. Yeah.
No, that's a great innovation from our side, I would say. Water coolers is far, I would say, MNC as compared to Indian side. So compliments to both of you for bringing this into reality. I just wanted to know that I just heard that IBM Watson has put many of the lawyers in US out of their jobs. Like that. Means this is the truth which you all know. 70% at least I have heard about it. So is that the truth that may prevail, or probably don't you think that it will prompt to the self-medication more?
To predict future is very difficult. So from what I see is that, can I provide quality healthcare from a general physician point of view to the kind of patients that come in. So that's the objective. And use this tool for doctors as a reinforcement of their learning, what they have, and have better outcomes on their patients. Whether they will go, the best part is that you will find our doctors. So if, for example, I'll give you something where, because I'm following this quite a lot. When Google introduced this multi-model thing which they experimented in Mayo Clinic, the doctors are finding it much more effective because certain things they miss out. And the more kind of data they have, if they don't miss out, it's beneficial finally for the patient. So the licensing and the authorities, who will you sue in the end? You will have to sue a human person, because the liability, no companies will take it up. So finally the person responsible just uses this as a tool and then it moves ahead. So that's why you need super speciality, you need all these doctors, because they know the best and how to utilize, or where the machine is wrong. So there is one other very, I was reading this book by Eric Topol. I think he's written a lot of books on AI, and I think he's a cardiologist. When he said that, he went through a lot of literature. There was this patient who came with a chest pain to him, and he really couldn't figure out what it was. Went through literature, couldn't find out what it was. Then he just took an intuitive decision of stenting him, and then he figured out that patient responds much better, but he had a kind of a problem which was not mentioned in the literature. So it was a discovery phase for him, and then he started doing more studies on it. Now this kind of thing, that is primary data, it's not here. You will have people you'll be mostly challenged to come up with new discoveries, something new all the while, and we humans are good for it. We've been doing kind of research and studies like that, problem solving. It will really help you, but there is more to it than what we, So this primarily it's a tool for reinforcing people to learn.
I hope it's not the sensational answer you're looking for. No doomsday ending where AI takes over. But at the end, I think there is some truth in the landscape. There is AI in terms of not going to, and this is how we are positioning it. And I think many should look at it from that angle itself. It's an empowerment tool. Nothing in more, nothing less. Yeah. Thanks.
Thank you.
Just a comment. So in the morning, when I wrote to my team saying that there's a event which is happening around AI, and I have a small valedictory at the end. So someone sent me an article where the Apollo, one of the Dr. Reddy, one of them had said that it's not that AI is going to replace doctors, but doctors who don't understand AI will soon get replaced. I think that's true for many of us. AI is general. I don't think AI will ever replace anything. But I think if we don't understand how to use AI, possibly, I think we would possibly get replaced by more competent people who would be able to use AI. But I think clearly there is huge, I think what you are going to do will help doctors diagnose and manage. I'm saying it's humanly impossible for doctors to, let's say, look at data sets the way I'm saying AI is able to look at it. Yeah.
Thanks.
Is it okay if I also go on with the question?
Yes, sure.
So basically, hallucination is something that is already solved because of citations. Now there is another big problem, which is bias. And in healthcare data sets where demographics and everything is different. So how are you looking forward to cope up with bias?
So one way is you have like here you see a lot of data set which is basically Western data set. You need to have research.
Yeah.
You need to have research. You need to understand what is the food affects a lot of your genotypes and climate and things like that. You need this kind of research, and then that data will actually help you. So biasness comes out of data. What is fair?
True.
So what is in that sometimes it comes out.
I'd like to take that also in a different way, and what you are mentioning is actually going to have an issue because when you look at secondary knowledge sources, they come, you have to question how the sources and the knowledge in fact comes into the data, the system itself. So secondary knowledge, when we are looking at especially indexed articles, we are looking at it as peer reviewed. And we are not asking it whether it's reviewed once, twice, reviewed by somewhere. Open access journals are there. So there's a research system already in line. Now, what's the best thing that can happen is when secondary meets primary, and when all of this happens, you can actually find out how much weightage actually the secondary had in the first place. So was that infused? Was that biasness put in, which can be done? People can jump loopholes. Many know this, and there are ways and mechanisms to do that. But I feel this will open up, and this is another advantage. So looking at it, we feel that there's more opportunity to play.
Also, you can plug it into your electronic medical record system.
Yeah.
And you can actually generate answers from, seeing
Personalized
patients.
answers.
Yeah.
So in the biases, which was 65 sample size and something came out of it and a study was done, you will have to actually play with real data, which is 65,000 times. The 10,000 times you'll actually work out that data and say, oh God, that 65 sample size doesn't fit here, or it does amazing actually. So this is where you're actually questioning it. So we are putting that in the forefront. And I believe the more people have access to this, I think that realization will happen. And whitewashing of a lot of secondary data can happen. I believe that is one thing that we can try and do.
Perfect. Thank you so much. Thank you so much to the both of you.
Thanks everyone. Yeah.
I would just take the opportunity and call upon Vivek sir, if you would please come up on stage and felicitate both Hans Lewis and Paulson Paul.